Hi and welcome. I'm Sari Cooper. Welcome to our website, the Erotic Intimacy Academy.
Hi, I'm Kelly Gwenham, co-founder of Erotic Intimacy Academy.
And this is one of our videos of what I wish I'd known. And it's really guiding you to understand kind of what brought us into the field of sex therapy and what we're hoping to really give to other therapists so that they become more sexuality educated as well as erotically informed.
Yeah, and gosh, there's so much that I wish that I knew before going into this, and what I've learned, in my years of experience has been so helpful now that I wish I could go back and tell myself, like, yeah, ask this, do this, make sure you're looking out for that.
And this comes just before we get into the topic for today. This comes after, like, I went to graduate school. Actually, before I even went to graduate school for social work, I did a year of family therapy training at the Salvador Minuchin Institute in New York. For those of you who don't know, Minuchin was one of the pioneers of family therapy. So I did a year of that. I did 2 years of graduate school.
Mm.
Then a couple of years after and after my practice I'd started, I did 2 years full-time externship at the Ackerman Institute for the family. In none of those arenas, nor in my private supervision, did I get educated around sexuality. What was your experience, Kelly?
The same until I sought it out to like gain that knowledge and get specific supervision for sex therapy. I was not taught it. It was not something that came up in my master's program. There wasn't even a human sexuality class in our couples. I specifically took like a couples therapy track with like many couples therapy courses that it did sexuality did not come up, which is wild to me because sex is can be an integral part of a relationship, right? And so until I decided to seek it out, it was not knowledge that was freely given.
Right. I did the same thing. I sought it out because I had a couple of cases in my private practice, and I didn't want to assume that the problems this couple were having, there were a couple of couples cases, was psychological or relational only in nature. I think I was doing a disservice by assuming that. So
Mhm.
today's topic, because it was one of the things that kind of blew my mind when I started specializing in sex therapy and getting supervision and getting the education, was the number of women, especially younger women, who came in with painful sexual encounters. I mean,
Mhm.
it was like coming out of the woodwork. I was like, oh my God, I cannot believe that there's so many young women who are having painful sex and continuing to have it. Uh,
Because it's kind of normalized, and also it's not described as painful, right? Uncomfortable, or maybe it's a little bit that sensation doesn't feel great, but it's still enjoyable. And so those words kind of desensitize the issue, and then people don't think like, oh, painful sex, like that's not supposed to happen.
yeah. So, I mean, just for your edification, I just wanted to add some statistics here.
Mhm.
Okay. So, according to a nationally representative study of American adults, 30% of cis females have experienced general pain, which is also known as dyspareunia, during vaginal penetrative sex. And another more targeted type of pain, which we see a lot of, is called vestibulodynia, which is pain at the opening of the vagina.
Mhm.
And while it's difficult to estimate the prevalence of vestibulodynia, studies using questionnaires of the general population in the US found that 8 to 10% of women have chronic vulvar or vestibular pain, causing pain with intercourse. So I just want to just kind of put some of those stats out there because um, it really blew my mind. And
Mhm.
I think the other piece that I think also blew my mind was the fact that so much of the time we're sort of acculturated to trust doctors. Doctors know what they're doing. Gynecologists, if they examine our female clients and tell them that everything looks fine, there's a sense of like, oh, we should just trust that their doctor knows what they're doing. Well,
Yeah.
no, like, first of all, there's so many gynecologists who get very, very little training around female sexual health, and they don't know what to ask themselves.
Yeah.
Um,
That was something
and
that really surprised me is that when I started working specifically in sex therapy and, it was suggested collaborate with the gynecologist and finding out or realizing that when I was speaking to the gynecologist or when I was referring people to gynecologists, that they were not focused on sexual health. And so a lot of their concerns were being dismissed or not taken seriously. And so learning that I needed to really refer someone to a gynecologist or a urogynecologist that is informed on sexual health.
right. And going back to what you said, Kelly, like the other thing is that because of our gendered society and a sexist society, to be honest, many young women are not acculturated, and older women, to advocate for themselves and to use the proper language to describe the sensations that they're having. So, in
Mhm.
fact, one of the studies here says 43% of American women aged 18 to 85, so the full gamut here, who report experiencing some form of sexual complaint, right? 43%, only 12% of those self report to a provider. Only
Wow.
12%. Right, right. So, one of the things I think that also is important for therapists to start to learn about themselves and how they can better help their clients is learning to teach a client how to be a better advocate for themselves in the medical field.
Yeah, absolutely. And that can be difficult, right? If we think about something like white coat syndrome, right, where you like show up and you like get really nervous and you go blank, it's really difficult to advocate for yourself and talk about something that can be incredibly vulnerable. And we're taught to be very private about our genitals and sex and anything to do with that, right? So it's very hard to advocate for yourself when you're having pain, which can, create feelings of shame around this. There's so much that goes into it. So as therapists and coaches, being able to identify all of the different things that can go into what is a barrier for someone to advocate for themselves at a medical appointment is really important. And knowing like, okay, these are the things that you want to ask, or this is maybe how you want to bring it up, and like what would be helpful to you to be able to like bring that up, or do you need a support there, something like that. Those are all important things that when I first started out as a therapist, or wasn't working specifically with genital pain or sexual health, like I would have never thought to consider all of the aspects that go into what can prevent someone from advocating for themselves at a doctor's appointment.
And because we do a lot of embodied work with our clients, we want to help them become more in tune with, first of all, what are the sensations that you're feeling
Mhm.
during this sexual scenario? Uh, what is the scale? So, like, instead of calling it discomfort or uncomfortable, um, calling it pain,
Mhm.
really like naming it, and then describing and sort of helping them describe where exactly the pain is if they can, because sometimes pain is referring pain, so it comes from another place and it feels like it's everywhere, but sometimes they can pinpoint it on their vestibule.
Mhm.
um, and then also, one thing that doctors do respond to is a scale out of 10,
Mhm.
for pain. So saying, out of your pain, out of 10 of your pain levels, what is it that you're feeling? What level are you feeling during penetration, during initial penetration, and then during when you're not having penetration? Because, by the way, there are conditions with which women are having pain even without any sort of penetration, even
Mhm.
just wearing tight pants, right? So that's a way we're advocating for the client to start checking in with their own bodies and owning and having agency over how they're going to talk about their pain.
Yeah. And I think something, that you brought up in the beginning when talking about when clients bring an issue and trying to figure out, is it relational, is it psychological, is it physical, right? Sometimes a couple will come in with an issue like discrepant desire. And then the more that we do an assessment, we find out, oh, well, it's not that they're necessarily lower libido. They have pain during sex, and then that creates anxiety. And then, right, like there's all of these complex things. And so this isn't just about when somebody brings the presenting issue as pain during sex or it being uncomfortable. It could also be presented in your office as like, we
Yeah.
have two different desires for sex, and like we just keep fighting about that, right? And doing that assessment to be able to discern like what is happening here.
Right, exactly. And in addition, for example, there are many people out there, a lot of you therapists are working with trauma,
Mm.
right? And we get a lot of clients who come in with some sort of past trauma, whether it's sexual or otherwise. But immediately, a therapist will point in their mind, consider that the trauma is the primary reason why someone might have low libido or is avoidant of sexuality or is having some sort of discomfort, right? Where and they won't consider like, oh, maybe we should have another medical professional on this team to consider whether there are some underlying injuries
Mhm.
or illnesses or imbalances in the vaginal flora that are contributing to this problem.
Mhm. You just mentioned something about injuries, right? So another thing that I had never thought of before when working with clients is to ask during the assessment, did you experience any injuries? Which, like horseback riding or during sports, anything like that. Like that did not occur to me to ask, which could, be, oh, like that leads to pain or that leads to fearfulness, right? Like all of these things that one question could really give so much information on and help with the outcome of the treatment.
Right. And there's so many other issues. For example, like, most therapists aren't necessarily going to ask their clients, like, how are your bowels? How
Mhm.
is your daily movements? Right.
And they
Because
might
they
be
don't
embarrassed. They might think, well, what does that have to do with it, right? So yeah, absolutely.
because they don't understand that this pelvic floor is very complex
Mhm.
and tightness or what we call hypertonic muscularity in one part of the pelvic floor actually impinges upon the muscle and the spasms that might ensue in the vestibule. And so they don't know to ask that because they were never trained. And it all, as you said, like, it might feel like they're being impolite.
Mhm. Yeah. Sometimes I'll start that with like, I know this might seem a little invasive or a little weird that I'm asking this, but I promise that it's connected, and like just ease into it that way. So it also makes the client feel a little bit more comfortable when I'm asking about their bowel movements or, going to the bathroom, going pee.
Right. I mean, we can expand this right to people who, are involved with anal play,
Hmm.
right? Because again, that's part of the pelvic floor. It's part of that whole region. And clients may not tell you what they're doing in the bedroom. They may not tell you that they're involved in anal play. And certainly therapists may not even, don't feel confident or qualified or um, like it's their place to ask about such specific things. So that's kind of what we're trying to help you feel more emboldened and more knowledgeable about.
Mhm. Yeah, and we're really excited to share this information. And this series is going to be continued conversations like this, things that we really wish that we knew when we started out as therapists.
Yeah, exactly. So thanks for checking in with us and listening to us. And each week we're going to be doing a little snippet like this of on the theme of what we wish we'd known.
Yeah, thank you for joining us.